privilege to introduce Maddie, Pesec, and Asaf Bitton, and I'll introduce Asaf, and Asaf can say a little bit about Maddie. But Bitton received his undergraduate degree from Brown and at UCSF before coming to the Brigham for his medical residency, including serving as chief president and receiving a from the School of Public Health. He's a professor of medicine in the Division of General Medicine at the Brigham and Department of Healthcare Policy at HMS. He's also a faculty member in the HMS Center for Primary Care. HMS began its Pursuing Inquiry in Medicine course several years ago, and since had to find mentors. I found the tutors, and to every student I ran into wanted to work with Asaf Bitton. And I speak at a GHM event concerning ACOs and really why. Tremendous command of changing primary care here in this country, feel for shifts at both macro levels. A record in the examination of the U.S. healthcare system, serving as senior advisor to the Comprehensive Primary Care Initiative at the Center for Medicare and Medicaid Innovation. Has gone on to measure and analyze the provision of care in low and middle income countries as well. So this serves as Director of Primary Healthcare at Ariadne Labs at the Brigham and the School of Public Health, and is leading Primary Healthcare Performance Initiative, which is an effort with the Bill and Melinda Gates Foundation, the WAG, and the WHO to measure primary care functionality in low and middle income partner countries and wide variation in performance, to understand variation in performance and tailor and improve initiatives to address performance gaps. While you can speak things, his last line is that he and Maddie will be speaking to us today. Costa Rica primary healthcare system in 1992 around, quote, basic integrated community health systems. Models remain understudied until now. And we'll get to hear and speak on how Costa Rica built a thriving primary healthcare system.
Thank you so much. Thank you for a really kind introduction. There are seats in the front. We promise we're not too toxic. And so would welcome if you want to sit and enjoy lunch. So I am really happy to be here amongst friends, new and old. It's really an opportunity and a privilege to be here. And the privilege is that Maddie Pesec gets to join us. And so Maddie is Maddie is a third-year medical student at Brown University, and she has been integral in leading this work on our team, and we are so happy that she's in the midst of clerkships. I think you're on OBGYN right now, and get her out of the ward or wherever you're supposed to be. So this is kind of a linking event. And Maddie, we work as a team on this work along with Hannah Radcliffe and other members of our team, and so we're going to team this presentation. And Maddie's done so much of the work, so I'm so happy you can be here. So we're about what Costa Rica has done and sort of build off of what Scott was saying. This is, strangely enough to us, an understated country when it comes to primary healthcare and actually health system reform. The epistemology why it's understudied is probably worth either discussion later or another inquiry another time. But I was hoping Andy Elner was going to be in the room because Andy, who was the associate director at the Primary Care Center, he and I trained in primary care together, been longtime friends and collaborators, and I told them like 15 years ago, we're going to make a case on Costa Rica. I don't understand why people don't know about Costa Rica. I had been there, he had been there, but we weren't friends with you yet. And we were just like, there's so much that Costa Rica's intentional model of improvement has to show and has to offer for other countries. Not as a blueprint, or I don't believe in like, go to a country, see what they're doing, and then automatically just plop another country. We'll actually kind of deconstruct those notions of what is useful about Costa Rica and what the narrative has been to date, and then talk about lessons learned, applicable in the U.S. context and in the global context with some work in this primary healthcare performance initiative. So, you know, a lot, maybe some of you in the room either are from Central America or have been to Costa Rica, know that Costa Rica has a unique political history, and we are going to use that as a jumping off point for this discussion. It's been a stable socialist democracy since the late 1940s. So before then, a lot of people don't know was an extremely unstable polity for the beginning of the 20th century and actually into the latter part of the 19th century. So it's not as if this, one of the things that we bristle against is this idea that Costa Rica is some sort of Shangri-La, place that's filled with, beautiful volcanoes and beaches and has no problems. That is far from the truth. But since the 1940s, it has been a democracy with incredible focus on social spending and on educational health system improvement and reforms. Middle-income country. You see the GDP up there, and it's a country in which the majority, but not all, health services are delivered in the public context. Though it has a fairly thriving private context that increasing in size and scope, especially with North American medical tourism. So we can talk a little bit about that. So here's been the narrative to date, and I intentionally don't want you to see names of authors. You can look this up. We're not trying to pick on that. But it's actually a paper that I was telling Scott about from AJPH, American Journal of Public Health from 2008, that both my interest and sort of frustrated me a little bit. So, with all due respect to our colleagues, they wrote a really nice paper, sort of the history of Costa Rican health policy, and kind of concluded that many of the success that we'll talk about in terms of life expectancy and public sector reform were predominantly due to Costa Rica being a stable democracy, overinvesting in social spending, social resources, public health services, not having an army. It's like mentioned 4 times. And it's true, Costa Rica does not have an army, and that is, it's amazing what you can buy with not spending money on an army. But not having an army in that part of the world, we're very amazing how much political strife, turmoil, and again, I don't need to tell this audience, has occurred literally next door to Nicaragua, or just a little farther in El Salvador, Honduras, Guatemala. So it's part happenstance, part policy, part luck, but they have been able, and certainly, to increase their human capital, human development, and are these contextual factors that we do not at all underprivilege, but not the whole story. And our thesis here, in a nutshell, is that the story studied part. So actually, in this paper, they made an amazing point, which is that if you look at the literature up to 2008, only in the English language, that also piqued our interest, you would see that there have been 3 times as many papers written about the history and functioning of the Colombian health system than on the Costa Rican health system. So those of you who sort of do some work in Latin American health policy would know the Colombian health system is not a very well-functioning health system. The Costa Rican health system is much better functioning. So for whatever reason, there's not been, or maybe that is the reason, dysfunction breeds more academic inquiry. But there's been this kind of paucity, or this sort of oversight of what is going on in Costa Rica. So we spent a couple of years and went to Costa Rica a number of times and spent a lot of time, we'll talk about the methods, and really found that the issue here has been really around intentional iteration, almost structural iteration and structural improvement. I didn't say structural adjustment. I said moving a way into, because actually there is a World Bank structural adjustment story if you care to know about Costa Rica, and how the Costa Ricans have very wisely used and ignored the World Bank's requested reforms in the 80s and 90s that are tied to money to actually do what they wanted to do, which is build a strong team-based primary healthcare system. This system has actually been iteratively built over decades, and that while the social development and policy environment has certainly been important, and not having an army has certainly been important, there is an element of care delivery, redesign, functionality, and wisdom that we want to share with you that we've been able to unearth. So methods for our work is first a very rigorous literature review. So we reviewed all the English and Spanish literature, and that's about 4,000 or so articles pertaining to Costa Rica, and got it down to about 179 Madeline, 135 Lilacs is the sort of Spanish language semi-equivalent of Madeline. Did other searches, and so you have Maddie to thank for diligently reviewing 290 articles and giving me and Hannah, our other co-author, authors a dissertation of only 100 peer reviews. So thank you, Maddie, for that. Maddie probably has read more articles on the Costa Rican health system than many other human on Earth. So, and our Costa Rican friends would agree with that, since they haven't even read all of them. So you did the work. So first that, and then second, and I know those of you who do qualitative work will also understand the amount of work that it took. So 51 total semi-structured key informed interviews, in person or on the phone over 3 years, 29 of which were quote-unquote government experts or government officials, but actually all the various levels and types of Costa Rican primary health care workers and people who deal with Costa Rican data, using snowball sampling over 2 long visits. So they're not visits, they were, I don't know, 4 months total. And we backtracked and sort of ran some of our findings back through the key informants to sort of say, does this pass the smell test? Does this actually make sense with your understanding and lived experience of the developed health system? And we sort of spoke to everybody from community health workers to the women who ran the health system for the last 10 years via roster science. So we try to get as many perspectives as possible. Why are we talking here? Because it might not be a big surprise, but Costa Rica has been a success story, and kind of like unpack layers of what we mean by success. So it does have the 3rd highest life expectancy in the Western Hemisphere. We all know that healthcare itself is not the principal producer of life expectancy. There are factors, social determinants, behavioral factors, genetics, etc., are important. So this might be partly due to no army and lots of social spending and a sort of stable country, but also we think and we'll argue is due to various investments in healthcare. If we dig one layer deeper, this is data from what Scott was mentioning, the Primary Healthcare Performance Initiative. This is an initiative that's aimed to try to produce standardized data for the 90 low and middle income countries across a harmonized set of global healthcare related metrics. And what I want to just point out to you for Costa Rica from their sort of is just 2 things. Number one, they have literally the top result out of all 90 countries in 2 of the areas, receiving appropriate treatment, DTP dropout rates, and more importantly, in every single area here, they have near the top in terms of best results. So these are a combination of process and outcome metrics, certainly MR, under 5 mortality, they're basically at the top, but facility-based delivery, TB control, any way you look at it, and we could go on and we could bore you with all these metrics, or you could take our for that Costa Rica appears to be consistently at near the top of any, certainly middle-income country that I'm aware of their PhD statistics for, and actually amongst the top, even if you start looking at some of the higher-income countries. Something is going on here. That's our task, and they do this by spending at levels that are much lower than even global average, which of course includes high-income countries. But so 970 in 2014, just to give you a comparative relationship, 8,500, 9,000 a year for healthcare. So doing a tenth of this, spending on healthcare and those kinds of results. It's a small country. 4.5 million, we're any cross comparison is by definition kind of unsteady and a little tricky. But it is important, and what we're trying to do is do bright spotting. What are countries and regions in the world that are doing things differently and getting some results because of that? So I'm going to hand it over to Maddie. She's going to walk through some of the early history, and then we'll keep tag teaming.
So before I go through a timeline, specifically how they developed this primary care system, I wanted to step back a little bit and examine how to think about the development of primary care systems. And definitely as a student, I originally thought of primary care systems sort of a linear progression. You start at one place, you make a couple changes, you build on those changes, and then you get to, voila, a great and wonderful primary healthcare system. Any of you who have children or who are closer to childhood may remember a game called Caitlin, and this is kind of how I originally thought of primary care systems. Like, you go a path, you encounter some obstacles, you jump the candy marsh, and then voila, you arrive at a primary health care system. But come now to think of Costa Rica's primary health care path more as this iteration. And I think that if you look at over time how they're building and changing, they're not really moving in a linear direction. They're saying, what do we have that's great, and how can we build on that, and how can we tweak what we have over time? And there's another board game that maybe resembles this a little bit more. In Monopoly, you're going round and around the board collecting $200 every time you pass go, and you're building your kind of real estate empire. And this is how I think of how in Costa Rica, specifically in the primary care, that they keep kind of inventing the system that they have over time, better and better. So this slide is a little crazy, but I wanted to have the timeline of primary health care so you can see this progression. In the late 19th century, it was a similar primary health care system to a lot of what was going on in the United States, a town doctor system where based on one town or one city limit, you had a doctor, and the doctor was a general practice doc who would deliver your baby, care for your baby, treat your sniffles, more or less effectively in the 19th century, but they did it all, and they were really in charge of providing medical care for that area. And this was not a particularly revolutionary way to provide medical care to a general population at that time. But what come into focus in the 30s and the 40s are these health units that start to develop throughout Costa Rica, and they actually developed in rural areas over developing in urban areas. And this is a theme you'll see throughout primary health care in Costa Rica, that it's an emphasis on prioritizing care in rural areas, that the cities are going to get the good care and the doctors there will figure it out, but let's try our new innovative primary health care in the rural areas and make that work. These health units are multidisciplinary from the very beginning. They had nursing staff, they had secretarial staff, and they had a physician in each of these. So a various number of different programs in the 1950s. There was one very influential program called a Hospital Without Walls. It was in the Western province. They essentially developed further this concept of multidisciplinary, geographically oriented healthcare. You would go out and assess the needs of the population that you're caring for and bring the hospital to the people. So that's where the name Hospital Without Walls came from. But the really neat and I think revolutionary primary care that developed in the 1970s was called the Rural Health Program. And there's a counterpart that's called the Community Health Program that subsequently developed in the urban areas. But the health program really focused on bringing prevention and what we in the States consider health, but this sort of prevention and primary care throughout Costa Rica and to really inaccessible areas. So there's this great narrative of nurses who would get to the towns they were assigned on any means necessary. And one of the kind of like mottos or sayings of the Rural Health Program at this time was by horse, by boat, or on foot, the Rural Health Program will reach you. And so they were literally riding motorcycles and horses up to the tops of mountains and bringing healthcare on a regular basis to their rural areas here. And in 1978, those programs combined bureaucratically to kind of even out the distribution of primary care. And in 1994, the model that we'll spend most of our time talking about was developed. So I just wanted to highlight for you a couple of themes throughout the primary care that was developed. And the first is this geographic organization, not organization around employers or organization around insurance, but rather organization around communities and cities. Second, the multidisciplinary teams that were established. Primary health care was looked at as the purview of nursing staff with augmentation by doctors for a long time. And this multidisciplinary theme has been existing in Costa Rica for a very long time. And then finally, this piece we'll talk a little more about later is data collection. And that's been really important since the 1970s in the way that Costa Rica executes its primary care.
Great. So, and we're skipping over just for the sake of time, and we have a longer report, by the way, if you'd like to read sort of more decade-by-decade history and development. But the 80s were a time of this kind of complex interplay with the bank. So Costa Rica went through a sort of capital crisis. They need loans to keep their medical and social infrastructure afloat. The bank comes in like they did in many countries in the early 80s. They offer loans with structural adjustment. The difference here is that the Costa Rican we're going to write a paper about this. There's a really fascinating interplay where they basically, I think they performed a Jedi trick on the bank, because they basically were like, yes, we will accept your loans with structural adjustment. We'll apply it to rural primary health care that is state-sponsored, and no thanks about privatizing our healthcare system. Okay, we'll do some measures, but that's about all we'll do. And somehow the bank bought it. And we need to find out more about that, because so many countries, maybe you've worked in some of them, that wasn't the case. And there's a general consensus about the mainly asterisk structural policies of the 60s or 80s. So what Costa Rica did, we think it's because this is not a system that was built on overnight. They had a rural primary health care system. You can see the obvious interplay between other, the barefoot doctor system, other CHW programs in Latin America. But keep in mind, the Costa Ricans, for better or for worse, have generally been more inwardly focused. It's not that they haven't known about other programs, but they did not model their program on any one other program. And then the real shifts occur in the early 90s. Again, actually, in part with bank money, which we find hilarious, because this is not the World Bank that was really operating and we are pretty sure it was not their intention to build this kind of model, a model in which they will describe care delivery teams, but also a model in which they furthered government control over large sectors of healthcare and continued to add feedback loops. This is from a paper that we published last year in Health Affairs, in which we distill, the learnings of Costa Rica into about 4 areas. But the first area is really important and really unusual, to be honest with you, especially these days where there's a real drive towards decentralization in public health sectors and LMIC. So what the Costa Ricans did in the 90s, starting in 1995 actually, was actually take the CCSS, that's the CAHA, the sort of Social Security Administration that was formed just a single payer for healthcare, and basically expand with a lot of battles. And we're sort of moving past a lot of very internecine warfare here within government, but they basically intruded on the lair of the Ministry of Health and said, we want to know and we want to control more aspects of the public delivery of healthcare. And healthcare to us is inclusive of the public sector. It's inclusive of what many other countries would call public health that the Ministry of Health would do. So vaccine programs, RMNCH programs, other vertical programs, but also data collection mechanisms. They wanted that all into a single payer that would also become a joint delivery organization and would literally pay the salaries of health workers. So for those of you that do work in the U.S., imagine like a nationalized Kaiser system or a nationalized VA system coming to play with all of that kind of payer-purchaser-provider dynamic. So this was a really important and unusual reform. And what it looks like is the CAHA, the CCSS, actually today it's the controller and the purchaser and the performance arbiter of primary health care and actually all health care, that's the public sector, which is the majority of healthcare in Costa Rica. And the Ministry of Health still has some Ministry of Health functions, but for instance, I kind of think if you want to know who rules the roost, who shows up for international meetings when they have to represent Costa Rica, the CAHA, not the head of the Ministry of Health, the boss, not the Ministry of Health. So they oversee the health regions and the health areas and then these teams that we'll talk about. Very cool. The second part is really building out these multidisciplinary teams on the foundation that Maddie talked about, structuring them to geographically impanel, meaning to have attributed people in a contiguous area for which to care for all of their preventive, promotive, and curative care needs and chronic disease needs over a period of time. And what does this team look like? Well, it has these 4 features. They know who they take care of. It's over a geographical area. It's in a defined unit of team, and that unit of the team is now sort of tasked with doing this all across the country. And the units of those teams and their performance are measured down to a small area level with incredibly fine data. And this is, again, this may be the boring stuff to some people, but this is unbelievable to us, the level to which they know the iterative monthly performance on key primary health care teams, and that these teams don't just do work, they really engage in in community work, they actually, and we'll show you in this slide, in 2 slides, what they do to sort of know and anticipate findings. So there are 7 health regions in Costa Rica. Take one representative region in the sort of northwest, Chorotega, and here it has overall 104 health areas. There are about 15 health areas per region, but Chorotega has 12. And in one of those regions, here there are a set of 5 EBAIS teams. Those are the names of the teams. So you're looking at about 1,000 teams spread across Costa Rica. So it's not one team per health area. You may have multiple teams depending on the need. And it's about geographic referral networks and distribution. So you use these teams in the community. One team, and we'll talk about the makeup of that team, is responsible for about 4,500 people, give or take. They provide comprehensive primary health care, and they provide data capture and acquisition and home-based care. They also provide medicines and supplies, and they are the gatekeepers of secondary care. And the team is made up of in no particular order. So Redis, which is a clerk who does intake and manages epidemiologic surveillance. And this is really important because they're on the top. These are just, acronyms. And these are the equivalent of community health workers. There is between the clinic, there is generally a clinic in every area, and the community. Top community-based health promotion outreaches, health education. Also, and this is probably the most interesting feature, they visit every household of every area every year, regardless if there's a medical issue or if they're in a vertical program. It doesn't matter. They go as both health workers and as data collectors, and they bring the data back to the Redis, and the Redis sort of integrates data, sends it to the health area sends it up to the region, sends it up to the Caja. That's visual. I mean, I know some of you do this all the time, and you know that that's unusual. For those of you very unusually prescriptive and detailed model, there is also a nurse who does nursing activity mainly in the clinic. The nurse might also do outreach. There's a pharmacist who works in the clinic dispensing medicine, so that the supply chains can manage through the pharmacist and the Redis, and then there's a physician. But it's not physician-centric. The physician may do some home visits, but as a physician myself, I think we all know, this is not about running everything through the physician-centric model. Having the physician do more acute care diagnosis and appropriate referral, and really have the other members of the team do a lot of the other health parts of primary health care. Here's the growth of the teams since their establishment, since their trial in 1995, and here's the estimated need. So nearly full capacity. One of the interesting parts is that the central agency basically redistributes and reestimates capacity on a yearly basis on the basis of performance metrics and need, but not in the way that you think necessarily. We've seen other performance contracts. So in many countries, what you say is bad performance gets punished. And Maddie can talk about this. Bad performance is not tolerated, and there's a kind of almost publicly transparent reporting in which you don't want your health area to be on the bottom, and as a manager of your health area, you may be fired if you're too many years on the bottom. But it's not that sort of, kind of nasty. It's from a planning perspective, poorly performing areas and or areas with high levels of inequity, especially the Northeast, like Limon, along the Pacific coast, will actually preferentially get more resources to stem the poor performance and more EBAIS teams. And so it's an overinvestment to meet the equity goals that are set out by the country. And then this whole system runs on these incredible data feedback loops, which are kind of complicated but kind of fascinating to sort of and try to tease apart how you take a notion and an ideology of high performance, high performing primary healthcare systems, equity, equity-based primary care, and you translate that into the daily work. So I'll hand that over to you.
So we look at when we look at this quality improvement, the more looked, the more errors I kept finding, and so if we look at time, there's a very simply think of it as a pay-for-performance model. And this actually was one of the kind of several things that the World Bank predicated their loan to Costa Rica upon. They needed to start to implement this pay-for-performance model. As you can see over the timeline, Costa Rica took it back and did it the way they wanted to do it. But originally it started out as a pretty standard, pay-for-performance system. And in the 90s, most of these metrics that they were using to assess quality were process measures, which is fairly consistent with the international community and the way that we understood pay-for-performance to be at that time. So the first task in this creating pay-for-performance was creating a registry. And stating that it was the 1990s and that computers were not really very prevalent in Costa Rica, they had to create these massive registries by hand of every clinic that they established. They did this in tandem with each primary care clinic they established. They built the data system right in, and getting to see, I was there right in the transition as they transitioned over to electronic medical records, but some of the clinics had their old books and their old binders, and they're just volumes and volumes of carefully detailed notes of every vaccine given, of every baby seen, of every date of every visit, and not just the doctor's activities, but also the activities of the community health workers, the activities of the pharmacists, and the activities of the nurses. And that was the first step here, was to create the registry. And then the second step, like we talked about, were the process measures. So, for example, registry would be to get a list of all diabetic patients in your health area, which is if you have 4,500 patients in your area and you have a prevalence of diabetes 10%, that's a huge list to manually compile. The second step then is to look every year at the percent of diabetics who were seen last year. Were seen in the clinic, or were they kind of lost to the system? And the metric against which health areas were getting financial incentives, purchasing department at that time. Over the past 5 years or so, they really ramped the idea of what quality metrics should be, and they actually, in their turn away from the World Bank, said, this is silly, we don't need financial incentives to do the right thing. We're healthcare providers, we want to provide great quality care. So they got rid of the financial incentives entirely and relied more on this drive by each healthcare system and each member of the healthcare team to perform well. And they have meetings monthly, yearly, depending on the level we're talking about, where all of the physicians will get in a room and see their numbers ranked. All the nurses will get in a room and see how they performed. And if you're at the bottom and you didn't do your diabetic foot exam, your boss is going to turn to you and say, what barriers are you facing? How can we support you to help you do more diabetic foot exams? Do you need a reminder? Do you need more time in the day? Do you need extra training on how to conduct it? And I think that approach is really different than the punitive, capitalist, money-based system that we often find in quality improvement schemes. So again, keeping our diabetes example, one of the metrics is the percent of diabetics who have achieved control of their blood sugar. So getting that number below 7%, those of you in the medical field, is the glycosylated hemoglobin number. But that metric that people are watching really carefully and pursuing. So we'll get the structure. I was really interested in the way they collected this data, especially before electronic medical records existed. This is an incredible feat to not only know an electronic medical record. I think it's easy now to click and say, I want a list of all my diabetic patients, or a list of all my patients whose hemoglobin is over 10%. They were doing this on paper with these massive registries, and I think that speaks to the amount of commitment that they were getting and the amount of importance that they give to these metrics and these numbers. So looking at one example of the way the data flows through are these contracts that we were talking about, where you have each individual primary healthcare team has, and we'll keep our diabetic example. So what percent of your diabetic patients have their sugars under control? And the purchasing department is the one we're giving out the financial incentives, and now just doing this kind of ranking or evaluation across all the different systems. And so when you see a solid line, I'm talking about data that someone is collecting kind of up to the national level, and then the dashed line is feedback of that data back down to the people who are providing the care. So the purchasing department actually goes directly to every single, all 1,000 clinics and does a sample of their charts, and they'll take 50 charts of 50 diabetics, and they will go through manually and say, is it over or under 7% for 20, 30, 40 patients. Then they'll collate that data up at the national level, and they'll get some feedback from the statistics department. Every month, each team is sending out information to the statistics department, and so the statistics department gives denominators for these samples that they're using. And then, right when I was actually in the country, I got to see this happen. They're doing feedback to the health region, the health area, and the EBICE team. And it's pretty good. But there's not actually a word in Spanish for empanelment. So they're doing empanelment without a word for it. Not actually a really set phrase of like continual quality improvement. Like, how am I going to translate this? And they were like, we don't really know what that is. And I'm like, how do you do this process of making things better all the time? And they're like, we're Christians. That's our job. We don't need that. We don't need a word for it. That's just what we do. So I got to see this process of feeding back data. And unfortunately, one of the women that I was working with, her clinic dropped about like 50% down the list. She was in the 95th percentile, and then she dropped far on the list. And she was in tears. I had a couple meetings with her. She was very distraught emotionally. And I said, are you going to lose your job? Why are you so upset? She said, I've been in business for 20 years. I'm not going to lose my job. I'm sad because this means that my patients have high hemoglobin. This is terrible. And she's sick to her stomach and really upset about these numbers. So this feedback of data happened to the region level. She had to talk to her boss. She was director of an area. She had meetings for 2 weeks with every single EBICE team in the area, talk to them about what they needed to get these numbers better for the next year. To trace this across all of the different ways they measure data at the statistics department, at an individual performance level for the doctors, for these contracts, you see just vastness of the demand management system. And I would implore you to remember that this all developed on paper before electronic medical records happened at all. And I think that electronic records will help them to simplify some of this. But to me, this speaks to an intense commitment to data management, to continual quality improvement, because this is a lot of work. It was a lot of work for me to map it. Nevertheless, for them to do it every month, every year, across 20 or 30 years that they've been doing this program. So let's talk about challenges, but I clearly get very excited about continual quality improvement data management. So if you want to talk to me about it, I'd be more than happy to.
And I think just, this is the first time that we know of that even internally in Costa Rica that this has all been mapped out. Don't worry about a test on the colored arrow at the end here, but just the sort of complexity and intensity of these loops and actually how they can be improved. Let's clear that we don't want to present Costa Rica as, again, others, getting back to these strange narratives of like this some magic land that everything's perfect. It's not. It's obviously not. There are really critical primary care system challenges and system challenges. We're just going to talk about PHC. One of the biggest challenges, and they know about this because they get iterative feedback from their populations, is that people in particular have intense aversion to the wait times for second referrals to specialty care. There's an ethos of service and functionality within that Costa Rican populace expects from their healthcare system, but not just limited to primary healthcare. And the fact that there are major wait times is an area of frustration. In fact, key government officials have fallen because of this political issue itself. Adapting to the NCD challenge, the non-communicable disease challenge, while I think Costa Rica has structural advantages here, has not been easy. The rural primary healthcare system was built to provide maternal and child care and immunizations, and it's taken 20 years of imperfect adaptation, including failed experiments with pay-for-performance with the management contracts of the late 2005 and 2008, in which, by theory at the time, and I see Bruce in the back, we've done a lot of pay-for-performance, and I know he has a lot of things that I share on pay-for-performance, but, when they were literally making 242 primary care measures for attached to monetary penalties or gains, that was impossible for them to manage. I think that's a big finding. It has a lot of direct utility to restore. I mean, we manage in American primary care at least 384 measures on a semi-regular basis, and though ACOs have tried to limit that, it's clear from the behavioral literature that you can probably only manage about 9 or 10 max. So adapting to them and then moving to EHRs is a big issue, and we'll relate to that, of course. And cost so we're touching about massive icebergs here, but cost is there's a lot, though Costa Rica efficient, available capital to fund healthcare is limited, and cost containment, especially among secondary and hospital care, is a major issue that they're highly concerned about. And since they've, I don't optimize, but they have a very highly performing primary healthcare system, they don't have a ton of levers to sort of reduce costs due to unnecessary utilization of hospitals. So that's a major issue. And then this growing private system, especially with medical tourism, especially with the inequities that it sometimes is now bringing in, especially around urbanized areas, is a big challenge. So we want to leave 10 minutes for discussion. We've said all these, but just to sort of summarize, we think that on top of context, it's really systematized iteration, which I think has been an intentional design feature of Costa Rica, and something that really puts it apart from many other countries and puts it in the category of some of the better learning organizations in healthcare that I've certainly seen the world over. And that's we of deep study and understanding some of the fundamental pillars. And for Costa Rica, that's been below, about this integration feature, the community and geographic engagement and empanelment. I was thinking about your story with empanelment. So I was meet the Ministry of Health in Argentina, and we've been with them for a couple of years. I told the Costa Rica story, sent them this document. The Deputy Minister and the Minister of Health said at our meeting, they were speaking Spanish, and all of a sudden I heard him say this word they understand either, and he said, "imperación." I said, because he's a friend, I said, "What? Is it a word in like Argentinian Spanish?" No, we just made it up because we need a word for empanelment, and we're going to do this stuff in Argentina, so we're going to need to make a word. So that's what we came up with. That's interesting. Other words you may have seen for this are rostering in sub-Saharan Africa and India. Some people use that. But yeah, it's this idea of teams assigned to populations in a reciprocal assignment that everyone agrees to. And this iterative data feedback. So, by the way, if you're interested in this report, it's available online. We have a little bit.ly. Let's see, our bit.ly is right here. So bit.ly/story of Costa Rica. We also have the health affairs paper. I guess with that, we want to make really all of our friends and contacts in Costa Rica. There are too many to acknowledge. They're acknowledged in the paper, but particularly Dr. Ryan and Jeremy, and then our mentors and also team members at Ariadne. So we'll take 10 minutes or more. So thank you for your attention.
Thank you for that wonderful talk. I just want to reiterate how well written the report is. So I want to read it. We have time for questions.
Question, because I guess this is being WebEx too. So.
I'm super curious because clearly these are human beings who are creating and maintaining and continuously improving this infrastructure. So I'd be curious to step way back and what is the enrollment process for medical school and the training in medical school? Because imagine who wants to go to the deep reaches, right? We have that struggle here in the United States. We used to have a pretty thriving public health system whereby you could pay back your loans by going to underserved areas, right? So the ethos that's created even within medical school to make this a little easier acceptable, or
I'll restate the question and let Maddie answer it, and she examine this. So the question is about how does training happen in medical school, and how do you get people to go to do rural primary health care in the outer reaches of different regions?
So I think one of the factors that helps this is the fact that the country is so small that the mastermind behind the system was also an appointee at the medical school and the School of Public Health. And he was able to make change on a government level in the Senate, in the laws, and then pitch and lecture the new incoming medical students about the model and the importance of it. I think the other factor that everyone has to become a general physician first, and then only the top 7-8% are selected to specialize further. So the expectation when you go into medical school is that you will be a general doctor, and you may be a general doctor for years before you specialize. And I think the final piece of it is that there is a mandatory 1 year of service that all physicians are required to do in a more rural area, and many of those physicians live the year in homestays in the community and end up staying. So I was able to shadow with one physician who did his homestay. He was one of the first cohorts in 1996, I think, physicians to roll out ICE model. He had a homestay, and he's been there for the last 20 years. He commutes in from a large city, but he's been with his community, delivering babies, caring for infants, caring for mothers, caring for families for 20 years. He's really an integral part of this community. And the other thing I would say is that more, I think, than making community-centered physicians is making this army of community health workers that supported this, because you do need the physicians to staff these clinics, but you also need nurses and data clerks and community health workers and pharmacists. And I think that the training programs they were able to mobilize for the community health workers were really wonderfully done. They were 12-month courses you had to complete after secondary school, and I was able to see some of their textbooks. I wish I could have brought a copy back. They were just really wonderful textbooks, grounded in respect for the community, grounded in the importance of why you're collecting this data, that this data is how you're going to make people healthy, and if you're a good steward of your data, you'll never achieve your goals of making the community healthy. So I think the training is really emphasizes that. And the last thing I'll say is that any physicians who were previously general doctors who wanted to come into the model had to go through a 9-month training course every Wednesday for 9 hours. Learn principles of the EBICE model or the primary care model that included epidemiologic surveillance. How do you manage a family versus managing a patient? How do you engage with the community? What are effective ways of doing education? Is it in a church? Is it in a school? Is it in a park? So physicians also were educated in this model.
Yeah, it's a lot of, I ask people on the street, is it a respected, basically in a top CHW, it's a very respected community position to have, and so, again, as Maddie was saying, this is not the professionalization, but the training, and Costa Rica are appropriately proud of what they do.
And follow that I would imagine the nursing training follows the same, the nursing will integrate it in the same way.
It's from the medical training, but also integrated with the School of Public Health, and I think nurses are probably a little bit better at why they're doing this, and probably they didn't have as far to go in the community health training. Speaking to someone who's in medical school, I think it's a little bit harder to get physicians back on the community health bus. The nurses usually don't have as far to go, if I can say that.
Of course, I agree with you.
Textbooks you mentioned, I mean, all these materials exist in Spanish that one could access it.
If one is really nice to the library secretary and she lets you into the basement, yes, one can get to them. But they're not online. They're not electronic. They're not PDFs, like in the offices of the people who took the courses in the corner. So they're not really accessible.
I look at you, Scott. There's a lot of historiography that needs to be done because it's just not. There's not a lot online.
Yeah. And it's in Spanish already, so for Peru.
Yeah.
Yeah.
Absolutely.
Go ahead.
Is emergency and essential surgery somehow integrated into this primary healthcare system?
Mm-hmm.
And I'm thinking, for example, cesarean section, which is part of maternal health care. So how are surgical systems integrated? And with the data monitoring that you were mentioning, are they measuring any surgical outcomes of any kind as part of this primary health care scheme?
Yeah, emergency
The
care.
question is on surgery and emergency and emergency acute care?
Emergency rooms are controlled by the health area, so they're separate from the primary care teams. They're controlled by kind of the next level up, and they're based on the needs of that community and the size of the community. Costa Rica is a very small geographic area, so getting to a surgical center for a C-section is not that difficult. Actually, all births...
But the roads are bad. They're very bad.
Yeah. All births occur in a secondary facility capable of having sections. When we looked at that first number, 99% of births occur in a facility. It's not a primary care facility. Yeah. It's a secondary obstetrics facility that has capable capacity for C-sections. Has to be done at the secondary level. Primary care is not doing any surgery, to my knowledge.
Big procedure, but not like not C-section. Yeah.
I was wondering about the kind of like social determinants of health, or like, because we talked about the manpower organization of the community health workers, but what resources do they have access to, like address housing or education or like transportation problems? Like, do they have resources that they can dispense? What's the structure of that?
The question on what resources are available to meet social determinants of health needs.
So I think that there's integration than in any other country that I've seen. And that's a lot of the job of the top is to identify those needs for housing. It's still, and I think, if we were in the universe, we would integrate those social aspects from the start. It is still, unfortunately, separate. But the TOPS and the community health workers are the ways that if they go to a house and they see that it doesn't have heating, they're going to get heating with the person, for example. Yeah. Is that your question?
Yeah, it's a huge feature of the system, and really the household visits. Not, I guess, some of the clinic visits, but it's the household visits that serve to systematically uncover and then at least provide a mode for addressing that. Not through the health system, but through the social resource connections. I would agree with you too, Maddie. I have never seen a system that has integrated. It's not perfect, but it's more rated and more keyed in on SDH than other places.
Yes, Scott. How does it get made at the very, for macrodecisions like at the very top, and how that's between like the MOH and CCD? I saw 88% TB cure rate. In some ways, so the only way it should be 100%.
Not their best, yeah.
Yeah, and so who are the I'm saying this is what we're going to focus on, or and how we to mobilize to affect that?
With the setting sort of strategy, and the head of CAHA is a deeply influential and political position. Well, I would argue one of the equivalent to cabinet member easily. Okay, on the higher end of cabinet member importance. As to how decisions get made within the CAHA, we talked to Dr. Saenz a lot about that, but not like in the systematic. I don't know if you have thoughts on.
I think that is opaque, and it's extremely opaque for workers on the ground that want to see their TB rates improve to get up the ladder through so many levels. But on the other hand, the Ministry of Health is supposed to provide that stewardship role or that guiding role. And so the Ministry of Health, for example, would say, gosh, our TB cures are really low. Let's write a report about how to improve them. They would give that report to the CCSS, the CAHA, and the CAHA would need to choose to allocate funds for a program like that. Hopefully a vertical program, hopefully a program that occurs through the primary care clinic.
But it's so interesting because MOH, our Ministry of Health, split. They're like, may we kindly suggest that you would like to take a look at these faults, and the CAHA is like, we'll do whatever we want. So it's powerful. In fact, I've heard a little pushback. I think some people resent the CAHA a little bit, or more than a little bit. It's not all rosy there. So
yeah. And the relationship of that bureaucratic integration, that the change that happened in the 1990s. One of our key informants, Dr. Musia, writes a whole thesis about the way that those interpersonal relationships flipped. There's still a lot of crossover. So Dr. Saenz was the head of the CAHA, but before that he was the head of the Ministry of Health. So they are in communications, but before this, the Ministry of Health ran the primary health care show, and then in bureaucratic integration, all primary care got moved under the CAHA, and some were very worried that it would become too medicalized because the CAHA had originally run hospitals, and the Ministry of Health rode on horseback to deliver vaccinations. And so that move of all of of the primary care shifting under the CAHA, there's a huge concern that we look at it and we're like, wow, so public health. Oh no, we're losing this like public health value that we have because the industry can't kind of protect it anymore. And a lot of the people who run the CAHA are not necessarily primary care doctors, but rather people that specialize and then became in charge of the hospital and then became in charge of all hospitals and then moved up through the ranks. So there are definitely concerns, definitely tensions, and I think it depends on who's in charge of the CAHA. I think Dr. Sayers ultimately stepped down over a fiscal area. We didn't talk at all about the money and the insurance part of this, but that's a whole other thing that the CAHA has to manage and juggle.
Actually, our future paper on the history will actually explore a lot of this infighting and trying to understand almost your sort of institutional identity, moving from a hospital-based insurance payer now taking over a care delivery system, but a care delivery system that's community-oriented, and so there are all these fistfights and battles, and it's a small country with not that many people, so they're really fighting each other and sometimes fighting themselves and hypocrites to what they used to say. So it's really interesting.
I think that the final thing that I want to mention about Costa Rica is how hard these people when I came to say, I'm going to come study your healthcare system. They were like, you're studying the problems. Let me tell you about all the things we have to do better. Let me discuss all of these things we need to work on.
Right.
We really need to get fewer people per team.
Yeah, the first thing I remember when I talked to Dr. Science like 5 years ago, I said, do you want to do this? Oh, yes, I know. Our wait time is horrible. Just unacceptable. You know, it can be hard to put this out internationally, but we should. And I said, no, that's actually not what I mean, we want to talk about that, you know, but that's what we want to talk about is this, you know, what you've done. And so,
And I think that feeds into this iterative improvement, constantly chasing better quality, and this deep ethos of service, and that the medical profession is not one of money, is not one of, you know, you get practice and then you're kind of done. We talk about like continual medical education. This is deeply ingrained into who they are and how they think of their healthcare system, and constantly chasing better, never being satisfied with the system, even though it's pretty great.
I think we're over our time.